Excellent. Good morning, everyone, and welcome to the latest iteration of the NB Heart Centre CV rounds. Many of you will have received the email that I sent out yesterday. Obviously, the mailing list is a work in progress, so if I've omitted anyone accidentally, I apologize. Just let me know, and I will add your name to the list. Rand, I especially apologize. You are not forgotten. We have done a couple of things. We've, first of all, moved our rounds now to 8 o'clock, which allows hopefully a greater audience participation, especially from the OR nurses and maybe even the ICU nurses. And I think this is a huge step forward. Thank you to all the higher ups that made this possible, JF and Farad in particular. And then secondly, we are recording these sessions, so they will end up on YouTube, which is great. Not only for the purposes of being, a resource for people who are not able to attend these in person, but also they will serve to advertise the Heart Center, which I think is a positive. So it behooves everyone who's presenting to do their best job possible, because it's going to live on in posterity on the internet. So with having said that, obviously any ideas, any suggestions are always welcome. We want to make this as good as possible, and thank you for attending. So we've got a total of 16, now 17 participants, and without further ado, I'd like to introduce Dr. Craig Brown, who is our senior most surgeon. Well, I guess, senior most actively practicing surgeon. And I will pass the throne over to you. The subject today is hypertrophic cardiomyopathy. And one of Craig's particular interest is septal myectomies in the setting of hypertrophic cardiomyopathy and asymmetric septal hypertrophy. Anytime I do a case to this effect, I always get Craig to join because he's just done so many of these and has a great sort of mindset around these cases. So I thought this would be an excellent topic. He's going to do this as a two-parter. The first part is today. The second part will be sometime in June. Today's part is really about asymmetric septal hypertrophy or hypertrophic cardiomyopathy, kind of a medical overview, and then the next session will be on invasive therapies, etc. So, Craig, thank you for doing this, and I will pass the reins over to you.
Okay, thanks, Ansar. Yes, it's a topic that's interested me for quite a while, and I think that really to do it justice, we'd need to spend a day or two at it. This is just going to be a very broad overview of hypertrophic cardiomyopathy, and hopefully we'll have some take-home messages and some learning today. If I can get this to work. Okay. I hope by the end of these two sessions, we'll be able to briefly explain what is hypertrophic cardiomyopathy, why people get it, where in the world and where in the body does it occur, and then also talk about exactly how it happens and how that influences clinical manifestations, and finally talk fairly briefly about therapy as well. That's going to be over two separate sessions, as Ansar has mentioned. Today we're going to be talking about just the basics of the disease and beginning about the initial parts of the therapy as well. So if we cast our minds back to what hypertrophy means, what I'm referring to is the thickness of the ventricular wall, in this case, left ventricular hypertrophy. So can contrast that to the normal heart. You can see, a marked change in the thickness of that wall. That's what left ventricular hypertrophy means. And when I think about left ventricular hypertrophy, I try to keep it simple in my mind, and I break it down into two major causes: physiologic versus genetic. And by physiologic, I mean any circumstance where the heart is appropriately hypertrophying in response to the enhanced burden of work. So one might think of things like where there's increased afterload. For example, aortic valve stenosis, or a subaortic membrane, or supravalvular aortic stenosis, or aortic coarctation, all situations where there's increased afterload on the left ventricle hypertrophies in response, an appropriate response to that burden. Another physiological hypertrophy might be that of an athlete. Again, a somewhat different type of hypertrophy, but also physiologic. Contrast that to the genetic causes, which are not physiologic. And within that genetic body, again, I break it down into two major types: hypertrophic cardiomyopathy and the phenocopies of hypertrophic cardiomyopathy, which are generally storage or deposition diseases, things like amyloid, Fabry's, mitochondrial storage diseases, Friedreich's ataxia, and a whole bunch of, there's probably about 40 of them now. So that makes it easier for me to understand. And there are ways, we'll get to them in a moment, to differentiate between those storage deposition diseases versus hypertrophic cardiomyopathy. But let's spend the remainder of our time primarily on hypertrophic cardiomyopathy. I want to cast your minds back. If you haven't seen this before, these are human cardiac muscle cells, and they're different than our skeletal muscle cells or our smooth muscle cells in a variety of ways. But what I want you to notice is that how they are branching and interwoven. And that is a marked contrast to skeletal muscle cells, which are sort of in one direction in a single planes, one after another. The thing that these the way that these are similar to skeletal muscle cells is the presence of these striations. So they are both striated muscle cells. There are a variety of other things that differentiate them from skeletal muscle cells, but we won't go into them so much today. Let me just go back for a second. Let's take a section of this sort of cardiac myocyte and look at it a little bit closer at the structure. And there's the cell membrane, and there's the nucleus, and there's only one nucleus in each cardiac myocyte, and there's mitochondria. But focus on this sort of tubular part of this muscle cell. And these are called myofibrils. And you can see that there's striations, and you can see better, even closer, that these striations are starting to be named. I think that's one of the jobs of histologists, is that they name things in cells. And if you look at it even more closely, you'll see that this is what it looks like under a light microscope, or even an electron microscope. And of course, all these striations have names. They've been assigned Z lines and A bands and H zones and so on. And what these really represent are different types of proteins arranged in a certain way. And so this unit is called the sarcomere, and it is the basic unit of contractile cells. It is what makes all muscle cells contract. And basically, if you look at this slide up here, this part of the slide up here, this yellow portion is the myosin. That's the myosin protein. The tan-colored, smaller protein is actin, and these slide against each other in response to calcium and other stimulants. The tropomyosin helps. And this framework is made with M lines and Z bands. And so these are all many, many different proteins that make up our contractile apparatus. And of course, proteins are made from genetics. And if there are abnormalities in genetics, then these proteins are malformed or absent or don't function properly. Hypertrophic cardiomyopathy is said to be the most common inherited cardiac disease. And I don't know if we all agree on that, because we can think of atherosclerosis as being partly inherited, and that's probably much more common. But about 1 in 500 people are said to have hypertrophic cardiomyopathy. And every time I go to a meeting, there's more genetic information about this disease. And now there are 20 genes implicated. Over 2,000 mutations have been found. So we are learning about this disease all the time. For me, it's a really easy thing to remember about what percentage of hypertrophs have obstruction, so HOCM, hypertrophic obstructive cardiomyopathy. And that's the 1/3, 1/3, 1/3 rule, or the third rules. When I first was introduced to this disease, it was thought that obstruction was a relatively unusual thing in this disease. As time has gone on, it became apparent that, in fact, most hypertrophs have obstruction. So the 1/3, 1/3, 1/3 rule refers to 1/3 having a gradient at rest, 1/3 having a gradient with provocation, 1/3 having no gradient. Easy to remember. I want to get back to the microstructure of this sarcomere for just a moment, because when you think about it, how does a genetic abnormality that malforms proteins lead to a thick heart and all the clinical manifestations that we're going to learn about? And it does that through abnormalities in protein expression, the way these proteins work, the force that is generated from these proteins, the lack of relaxation. These in turn signal intracellular pathways, intranuclear pathways. So epigenetics and genetics are involved with the expression of a variety of factors that we're still learning about. And these factors then go on to muscle, myocyte hypertrophy, and so on. This part of this pathway is entirely physiologic. So the myocyte hypertrophy that occurs is the same hypertrophy that occurs with any other type of hypertrophy. It's the overabundance of these factors that cause it to become a non-physiologic and pathologic problem. Here is a normal heart. Nice, thin, free ventricular wall. The septum is thin. This is the right ventricle with a normal right ventricular thickness. That's the aortic valve. That's the left atrium and the mitral valve. All this is normal. And if you look at this under the microscope, you would see cardiac myocytes. The blue things are nuclei. And these cells, you can see, are all sort of traveling in the same direction. They're orientated appropriately. There's not much in the way of interstitial spaces. So this is a normal appearance. Contrast this to a micrograph that unfortunately is not magnified as much as slide A. So this is about 1/3 the magnification. If it was proper, it would show that this is very hypertrophied and that these cells don't seem to be traveling in the same direction. This is called myocyte disarray. And also, if you look carefully, there's lots of space between the cells. This is interstitial space that shouldn't be there. And if we had the appropriate stain, we'd see that this be filled with collagen. So there is fibrosis occurring in this muscle. Not only that, not only is the fibrosis occurring between cells, but it's occurring around blood vessels. See that little blood vessel there? Surrounded by collagen. That shouldn't be part of the problem with this disease. And here's what it looks like. Very thick walls, very thick septum. Even the right ventricle is thickened, and that's one of the features of hypertrophic cardiomyopathy. The right ventricle is not normal. And look at the size of these papillary muscles. Again, a feature of hypertrophic cardiomyopathy and something that sometimes we need to deal with in the operating room. Well, this disease takes on different forms, and for reasons that relate to environment, epigenetics, and genetics. So some people with exactly the same genetic abnormalities will have different morphologies. And these are some of the common forms that hypertrophic cardiomyopathy assumes in our patients. So if this is a normal patient, it could be a genotypically abnormal or genotypically positive patient with a phenotypically negative situation. But let's assume that's just a normal patient. This is a situation where there's basal septal hypertrophy. This is diffuse septal hypertrophy. And this is global left ventricular hypertrophy. Let's switch over to this one, which is mid-ventricular hypertrophy and apical hypertrophy. These ones are the ones we most commonly see. We don't often see focal mid-septal or focal free wall hypertrophy, but it definitely occurs. This part E refers to a burnt out hypertrophy See how the walls are becoming thin again, and the left ventricular volumes are now much, much higher. This patient is in deep trouble with congestive heart failure. Well, let's talk quickly about the natural history. It's one of the few cardiovascular diseases that can manifest at any age, so pediatrics, adolescents, young adults, all the way up to the people in their 80s. And when we think about people dying in their youth from sudden cardiac death, well, that's probably hypertrophic cardiomyopathy. It's the most common cause of sudden cardiac death, with a rate of about 0.5 to 2% per year. However, and this is really important to understand, most people with hypertrophic cardiomyopathy have normal or near normal life expectancy with an annual mortality of less than 1%. When you think of the clinical picture of this disease, it's easy for us to think about aortic valve stenosis, and you will then know most of the clinical manifestations of this disease. Remember that about 40% of these patients are asymptomatic or minimally so. So many people don't have symptoms. There's about 20 million people living with this disease. We've only identified 10% of them, and 40% of that 10% have no symptoms. There are 4 major pathophysiologies, and we need to understand them to make sense of the clinical manifestations. Diastolic ventricular dysfunction or impaired ventricular filling causes heart failure, dyspnea. Left ventricular outflow tract obstruction causes angina, syncope, dyspnea. There is an imbalance between myocardial oxygen supply and demand, unrelated to the obstruction that may occur. And that occurs because of the hypertrophy, the fact that interventricular pressures are high, and also because of the fibrosis that I talked about surrounding these coronary vessels in the muscle. Well, that imbalance causes angina, probably leads to sudden cardiac death in some individuals as well. And cardiac arrhythmias are the 4th pathophysiology. Things like atrial fibrillation, which is very common in this disease, about a quarter of people get it. And non-sustained VTAC, which often causes syncope and presyncope. And of course, the most malignant is ventricular fibrillation, responsible for the sudden cardiac death of these people. So these things are also seen in aortic valve stenosis. So it makes sense and makes it easy for us to remember how this disease manifests. Physical examination is helpful. It can be normal, but usually we would feel an apical impulse that is broadly and strongly felt and displaced. There's a prominent A wave in the jugular impulse because the atrium is contracting against the stiff ventricle, and that's why you hear a heart sound. Go to this YouTube address, you'll find an excellent audio video learning for the 4th heart sound. I recommend it. The systolic murmur is present when there's left ventricular outflow tract obstruction. It's accentuated and reduced by certain measures. So anything that reduces your ventricular filling will make the murmur worse. Anything that increases afterload will make it less audible. ECG, I don't find very helpful because there is no characteristic pattern. It's almost always abnormal. Primarily, it's left ventricular hypertrophy. The diagnosis is then usually made by transthoracic echo, which demonstrates that the end diastolic wall thickness needs to be 15, 13 millimeters, somewhere in there, depending on what continent you live in. The Americans and the Europeans disagree on that definition. But the echo is also very useful for looking at, is the hypertrophy asymmetric? Are there places where it's thicker than others, particularly the septum? If there are gradients, how big are the left ventricular outflow tract gradients? Is the mitral valve leaking? And is there systolic anterior motion of the mitral valve? Is the mitral valve morphology normal, including the papillary muscles? And what about the aortic valve? I've found that they usually are sclerotic and usually are leaking a little bit, probably a reflection of long-standing turbulence just a bit upstream. The MRI is increasingly useful in this disease, especially if the echo windows are not great. Late gadolinium enhancement is a marker of fibrosis. It's found, therefore, great use in this disease where fibrosis is part of the diagnostic pattern of the hypertrophy. It also gives us information about chamber volume and ejection fraction, and can show other diseases that are phenocopies like amyloid and Fabry's have diagnostic features on MRI. Endocardial biopsy is not often helpful, but sometimes can be, especially if we're really stumped about what the cause of hypertrophy is. Remember that DNA analysis is really important. Once we have the diagnosis, it helps with genetic counseling, with family screening, and because we don't know everything about the disease, it also improves our knowledge base. I'm going to say quickly, I don't have much time left, that the goal of therapy, for the most part, is to reduce symptoms and improve quality of life. That should be where our focus is. That's where most of the data lies. Lifestyle is important. Low intensity aerobic activity is encouraged, and even medium intensity is probably okay, though safety data is still lacking, and there's 2 ongoing prospective trials about that. In fact, they're investigating high intensity aerobic activity. Competitive sports are generally discouraged. We recommend avoiding excess alcohol, stimulants, dehydration, and temperature extremes such as saunas and hot tubs for obvious reasons. And we recommend caution with phosphodiesterase inhibitors for erectile dysfunction because of its changes on afterload. Again, pharmacological therapy, I'm going to talk very briefly about this and end up on that today. Again, the goal is to reduce symptoms and improve quality of life. None of these pharmacological therapies change longevity or alter the progression of this disease. Beta blockers are the cornerstone. They slow the heart down, as we know, and decrease contractility, improve ventricular pressures, so they improve many of the symptoms of this disease. Calcium channel blockers, particularly verapamil, can be used in place of beta blockers if they're not tolerated. Disopyramide, a very useful class 1A antiarrhythmic that has found a role in this disease. It's a powerful negative inotrope, and that's how it works. It's very useful for left ventricular tract obstruction. Caution should be used because some of these patients are on amiodarone, so you want to be watching your QTs for sure. Diuretics sometimes have a role, especially if there's no outflow tract obstruction and if there's congestive heart failure. ARBs make some sense, and there was hope that they would influence the progression of this disease because ARBs alter the signaling for fibrosis. So 2 trials have been done or are ongoing. One has been done. That's the INHERIT trial. Losartan was negative using an MRI late gadolinium enhancement sort of target. It did not show decrease in fibrosis. The VANISH trial, which is using valsartan as their active group, is ongoing. It's looking at a broad range of outcomes, including fibrosis, but also looking at heart outcomes as well. That started in 2017, it's still recruiting. Remember that cardioversion is really important because these people, when they get atrial fibrillation, will know it. And so it makes a big difference to their symptomatology if we can convert them amiodarone and electrically. And of course, oral anticoagulation is really important. 1/4 of these patients will get atrial fibrillation. And people that have hypertrophic cardiomyopathy and atrial fibrillation, 30% of them will have thromboembolism. So oral anticoagulation is really important. It doesn't probably matter whether you use warfarin or the newer ones. Next time we talk, we'll be talking about a little bit about pathophysiology, especially SAM, and then we'll be talking about invasive therapies. So that'll be probably in June sometime. Hope I've given you some exciting information. Please shout out any questions. Thanks a lot for listening.
Thanks, Craig. That's excellent. So far, comments have been predominantly congratulatory. Yeah, and they continue to be congratulatory. No, thank you. That was really good. That was an excellent overview. And I must admit, you know, you kind of, especially as a surgeon, me specifically, you kind of get pigeonholed on the therapies and you think less about the pathophysiology. So I think that was a fantastic overview and, you know, will kind of set us up nicely for the next talk. Just from your standpoint, without obviously getting too much into what part 2 is going to be, when you look at some of our therapies, you know, we do very little to actually change the course of the disease. most of our therapies are kind of treating the sort of the secondary outcomes thereof. How do you sort of see that changing over time? Like, do you see our focus being more on the primary pathogenesis of this versus the actual secondary outcomes, or do you see us always sort of being treating the secondary outcomes of these diseases?
No, no, I sure hope not, Ansar. I think that we're going to see some amazing biochemistry and biological treatments for this disease. There are some ongoing incredible trials using different compounds that interfere with some of those signaling that I talked about early in this talk to absolutely prevent the progression or even the development of the hypertrophy and the disarray. So there are trials now in humans. There's already been one small trial in humans, and there's now a prospective randomized trial with one particular substance that we'll go into next time we talk. So yes, this disease, we're going to have a cure for this, and it's going to take years yet. But in the meantime, what can we do for our patients? Well, we have some interesting invasive therapies, and some of them we do in this heart center, and those make a significant difference to the patient's lives. So that's comforting, but in the long term, we need a cure.
One question from the audience. In patients who have poorly controlled hypertension with underlying hypertrophic cardiomyopathy, how do you sort those? Or sorry, maybe let me clarify that question. I'll say it exactly as it was listed. How to sort out hypertension that's poorly controlled from somebody who's got, say, a hypertrophic cardiomyopathy? There you go. That's probably the question that's being asked. Sorry, JF.
Yeah, and that can be a real issue, especially in the elderly people who have had a long-standing hypertension, or if you're thinking also about people that have concomitant aortic valve disease too. So it becomes a bit of a challenge. Part of it is if there is asymmetry to the hypertrophy, then that tends to argue towards a hypertrophic cardiomyopathy. In those other diseases, it tends to be a more global hypertrophy, although not necessarily, but usually it is. The fibrosis that occurs with hypertrophic cardiomyopathy is said to be fairly characteristic, although not pathognomonic, of this disease. So MRI with LGE is helpful in distinguishing these two entities. And biopsies can also play a role. So those things can help to differentiate between the chronic hypertensive plus or minus aortic valve stenosis versus hypertrophic cardiomyopathy.
And then the last question, which I think really just sets you up for the next talk, is how often would you do surgery for a type C hypertrophic cardiomyopathy, as shown in your picture, to remove a piece of septum?
Right. So that was to remind everybody. Oh, there it is there. So that type C, that's the global or diffuse septal hypertrophy. How often do we operate on those? So, I don't want to steal the next talk's thunder, but exactly. Definitely that can be a target for surgical therapy. It has been a target for surgical therapy in this heart center and in other heart centers. The results, I will say, are less impressive. The surgery is technically more difficult and more dangerous. And so, our discussions with patients and patients' families would certainly impart those ideas. And I think the important to understand is that resection of as much of that septum as possible is key to the results that can be achieved. And sometimes alternate approaches to that septum, not just transaortic, are necessary to resect as much as possible of that septum.
Perfect.
So how often we do it? It's probably less than 20% of our cases, for sure.
Wonderful, Craig. Thank you so much, and we'll look forward to part 2 sometime in June. Obviously we'll advertise those dates. Thank you everyone for joining. Our session next week will be delivered by Dr. Jean-François Légaré, and we'll speak to the COVID-19 pandemic and its impact on cardiovascular care. Obviously, I'll send an email out to that effect. The Zoom link will actually stay the same, for the remainder of this academic year. So in case you're wondering if you see an old Zoom link from last week or the week before, it works. This talk will be posted on YouTube shortly in the next 24 hours. And then I'll also send a copy to Sue Morris so that she can send it from a teaching perspective as well. Thank you everyone for joining, and have a great rest of your day, and carry on.
Bye.